بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Welcome my colleagues. Today we have a very interesting lecture about acute kidney injury. It will be presented by Dr. إسماعيل ابراهيم. He's our consultant of nephrology, and he has a very experience, more than 40 years in the field of nephrology, 45 years in the field of nephrology. He is member of the Royal College of Ireland of Internal Medicine and Nephrology. Welcome, Dr. Ibrahim.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'd like to thank very much the organizing CPG CME committee for inviting me to share with you my experience. Actually, the acute kidney injury comes in the series of acute injuries in the vital organs. You might hear about acute brain injury, acute brain injury, acute liver injury, acute lung injury, acute coronary syndrome, and these are having crosstalks between those vital organs and others. You're going to find patients with cardiorenal syndromes, pulmonary renal syndromes, hepatorenal syndromes, and so on. And these might culminate to multi-organ dysfunction failure in ICU settings. Anyway, without further delay, we're going to start our talk about the acute kidney injury. This is my agenda for today, and I'm going to comment further at the end with the closing remarks and the pearls and take-home messages, which are really very crucial. In the meantime, I'm going to spend some time on the controversial contentions like the contrast media about the so-called renal troponins, like the biomarkers for the acute kidney injury. So let's start with the acute kidney injury. As the word acute connotes that we're talking about injury which takes place in hours, days, and this complicates quite a great deal of patients in the hospitalized patients, and those especially in ICU setting. As you know, the acute kidney injury is going to progress to the CKD or the end-stage kidney disease, and ultimately those patients might necessitate renal replacement therapy, and they are fraught with a high mortality, which can go up to 80%. Historically, acute kidney injury or acute renal failure was first coined by Dr. Smith in the 50s, and this was preceded by different names like ischemia renalis, acute Bright's disease, war nephritis, crash syndrome, acute liver necrosis, and as I mentioned, that the Homer Smith just was credited for the introduction of the term acute renal failure. Also, just to know the magnitude of the problem, the USRDS just in the estimated the yearly incidence of AKI to be 522 per 100,000 population, and the significant increase in the cost accordingly with the, for example, like a 0.3 milligram per deciliter, which is equivalent to 26.5 millimole per liter, might increase the cost by almost 5,000 US dollars. And so on, so that there is a high anchored cost related to the AKI, even after survival from the AKI. So what's the acute kidney injury? To go back again, it's within hours or days occurrence of disruption or shutdown in the kidney function, with which really includes injuries, and injuries structure-wise, we are related to the proteinuria, to the hematuria, and the almost a bad thing about it looks like a remodeling process or maladaptive repair. So remember that the acute kidney injury patients are not going to recover the way we are thinking that they are going to square one, but actually they end up with a scarring of the kidneys. Apart from the function, we mean by the function the surrogates of the kidney function, the creatinine, urea, and others which could be non-identifiable. We know only the creatinine and the urea as well known in the biochemistry routine workup. So there is a decrease in GFR as we mentioned. And also remember that urea and creatinine, there is nothing called actually a normal creatinine or urea. It's really a range, and it depends about the patient's age, about the patient's comorbidities, and others. So I mean, the creatinine could be, say, for example, 1.2 for a patient 29 years old or 30 years. Is different from 1.2 for one in the 60s, different from 1.2 for a patient, say, in the 80s or 90s. You'll find that those patients will have different estimated GFRs. So the word azotemia, just to mention the word azotemia and uremia, there's some people are confused, muddled about those two terms. By azotemia, we mean that we're talking about the chemical findings of high creatinine, high urea. By the uremia, we mean that there will be clinical symptomatology with the further worsening of the azotemia that might end up in the need for renal replacement therapy. Again, just some terms for the basics also, that the oliguria, we mean by that, we're talking about a urine output less than 500 ml, whereas the anuria, we're talking about a urine output less than 200, and you'll hear a term non-oliguric, which is really more than 500 ml, and just to mention the polyuria, more than 3 liters in adults. So, is the term AKI, acute kidney injury, is synonymous to acute renal failure? Or in other words, the acute kidney injury is better term or worse term? Just to mention, the acute renal failure is like a consequence of the AKI. So the beauty about AKI, the word AKI, the term AKI, it's really a collective term. It includes different outcomes. The patient might recover, the patient might go into acute renal failure. We'll explain this one later. Chronic kidney disease, etc. So the AKI is just, it gives some degree of renal impairment, but not necessarily severe enough just to go for the failure and the need for renal replacement therapy. This holds true also for the acute tubular necrosis. Whenever we're talking about the term acute kidney injury, is it really the same as the acute tubular necrosis? Again, the acute kidney injury term is much more wider term, and it encompasses different etiologies, pre-renal, renal, and post-renal. So whenever we talk about the acute tubular necrosis, is one entity of the acute kidney injury, which is related to the renal or the intrinsic AKI. So you see that the acute tubular necrosis term and the acute renal failure terms are really very specific. But when you talk about the acute kidney injury, it's a much more broader term and includes more than that. So for the definition of the AKI, there are different definitions related to the system we're using. We might hear about Rifle criteria, Akin criteria, KDIGO criteria. We mean by the KDIGO, which is the most well entrenched in nephrology. You'll find that the KDIGO and the KDOKI guidelines, always these are two bodies which are really the most two prominent two bodies which are authorities from which all issuance of the guidelines take place. So according to the KDIGO, the definition of the acute kidney injury, it comes from the sudden loss of kidney function clinically manifested as increased creatinine or plus or minus a urine output drop. We have 3 stages, stage 1, stage 2, stage 3. Just for the sake of time, the stage 3, just if we increase by 0.3 milligram per deciliter, equivalent to 26.5 millimole per liter in 24 hours or increase by 1.5 to 2 from the baseline. We mean by the baseline is if we have a record of patients in the system, we can go to the least figure of the patients of creatinine. Say the patient had in January a creatinine of 60, and now we are in October, a patient is having a creatinine of 100. Still, despite that, they are within the range of the normal range, but this is acute kidney injury because it's more than 50% or more, one and a half times. So this, of course, this is related to the electronic alerts system in the different hospitals. So it's not a matter of like I'm going to to send to the physician or the practitioner that the creatinine is whatever figure and the estimated GFR is so and so. This is not enough. But actually, there should be a system of alerting that according to the system, this kind of patients had a creatinine earlier on, which was so and so, and nowadays the latest figure is really increased by more than 1.5 or to 2 times from the baseline. So the baseline is very important whenever we are trying to trace whether the patient's having acute kidney injury or not. So just to go back to the rifle again and the criteria, the rifle criteria on the left here, having the risk, injury, failure, loss, and stage, and the Akin criteria having the stage 2, 1, 2, 3. So they came the KDIGO and they made a combination of both rifle and Akin criteria in terms of serum creatinine and urine output. And we have acute kidney injury. By definition, you're talking about acute kidney injury for up to 7 days, whereas you're talking about, as we're going to show, the acute kidney disease from 7 days to up to 3 months, whereas the chronic kidney disease up more than 3 months. And these are in terms of functional criteria, as we mentioned, with the creatinine, and structural criteria related to the proteinuria or the active sediments like RBCs or RBC casts, etc., or white blood cells, pus cells. So if you go back to how common is acute kidney injury, actually the estimates depends on the definition used under the population under study. You might get patients with primarily surgical problems, or patients with primarily medical problems, and you'll see that there will be different ways of recording or reporting the incidence and prevalence of those kind of patients. But the things which are noteworthy is the acute kidney injury has become progressively more common, with an almost 20-fold increase in incidence over the last 25 years. And also I'd like to mention that the 25% of those patients developing acute IE while in hospitals, 50% of those cases are iatrogenic. So remember that we should really try to be cautious about the implementation of the nephrotoxic medications or agents with the patients, especially in inpatients. The reason for that is that the development of AKI per se is an inpatient in an inpatient setting is associated with a more than fourfold increase in the risk of mortality. So which patients are at risk for the development of AKI? It goes without saying that we're talking about if patients having pre-existing CKD, or there are comorbid conditions, primarily diabetes and hypertension, or in the elderly, frail patients, or those patients who are having a very clear history about volume loss, or those with nephrotoxic medications, or medications which can affect the autoregulation of the GFR, and the radiocontrast material exposure. We're going to talk further in detail later on. Sepsis, surgery, rhabdomyolysis, solitary kidneys, and urologically benign prostatic hyperplasia or malignancy. And these are the acute conditions very well known, encountered with this kind of patients. If we talk about the etiology, the classical teaching we have it related to the microanatomy of the acute kidney injury, the pre-renal, the intrarenal, or post-renal. And this is the way they used to teach it in the medical schools. The acute kidney injury, pre-renal, intrinsic, and post-renal. And the intrinsic includes the components of the kidneys, the glomerulus, the tubules, the interstitium, and the vasculature. And for the tubular damage, we're talking about the ischemic and the nephrotoxic. However, recently there have been changes. They wanted to rename those pre-renal, renal, and post-renal as functional acute kidney injury for the pre-renal and the kidney damage for the renal and post-renal. And this is quite clear from the permutation of findings you got related to the function and damage. You might get different combinations of those, and which will ultimately affect the prognosis and management of those patients. To go back to the basics again, the urea and creatinine, as I reiterate to mention, they are nitrogenous waste products. Urea is primarily a metabolite of dietary protein and tissue protein turnover, creatinine for the muscle creatine metabolism. To mention, the creatinine is a more reliable indicator because of it's really devoid of problems related to the diet and hydration. Whereas to mention also in Europe, they are using the whole urea molecule compared to the United States, where they only use the BUN, or creatinine, blood urea nitrogen, which is roughly 1/2 of the blood urea. And this is the generation clearance of the creatinine. Just for your information, this is the main theme I wanted to really give you this message, that creatinine has long been used as a marker of kidney function. Although creatinine is easy to do, its sensitivity is poor by the end of the day. And because the creatinine has other defects, it takes 48 to 72 hours, 2 to 3 days for serum creatinine to creep up after initial kidney injury. So the serum creatinine starts to rise only when more than 50% of the kidney function has been encroached upon. In order to be reliable, creatinine needs to be in a steady state. This is for the acute kidney injury, and for the chronic kidney disease, it's well known that most of the time it's a steady, unless it's acute on top of chronic kidney disease. To compound this problem more, I think this is a very practical point. When we do our rounds in the morning and we are waiting for the lab results for the creatinine, we might miss it. So it's going to take to be one more day delay just to know that the creatinine is really up. So from the time of an acute kidney injury to its recognition, it may take actually a couple of days. So this delay has a lot of impact on the prognosis and the management. To go back again to the prenatal, this is well known from the hypotension, from the decreased renal perfusion, and the abdominal compartment syndrome. The abdominal compartment syndrome is reported to be in 30% of cases of AKI in critical ill patients. And it's simply measured by the urinary bladder pressure. If it's above 20 millimeter mercury, so there's abdominal compartment syndrome. And the abdominal compartment syndrome, it looks like it will cause congestive nephropathy, like that what we're talking about, the hepatology, the congestive hepatopathy, because of the cardiac issues when they are chronic ones and really very substantial cardiac issues. You'll find that there is a back pressure on the liver, and we get that so-called congestive hepatomegaly. The same holds true from the same concept that we might get something now well recognized. It's called congestive nephropathy. So it's not a matter of only the kidneys will be from the arterial side, there will be ischemic, low perfusion or hypoperfusion of the kidneys from the arterial side, but also from the venous side, there might be a delay or hindrance of passage of blood back to the venous return to the heart. So both the arterial and venous implications are really fraught with a lot of devastating effects on the kidney function. And just this one, for the sake of causes, just to enumerate the cause of the hypovolemia, impaired hemodynamic instability is very important for acute kidney injury, and systemic vasodilation and increased vascular resistance. If we go straight from the pre-renal to the post-renal, we might find this one in the urology, of course, this area, the extrinsic compression with the benign prostatic hypertrophy, and this is equivalent in the males with the cervical CA in the females. Because we have one patient, I don't know, Dr. Shoshan is not around. We have one patient like that, by the way, currently admitted in the hospital here. And the oncologists, and they are working on ovarian cancers, and the patient having bilateral hydronephrosis. To get a bilateral hydronephrosis in a lady, there's some problem related to the cervix and cervical area from the cervix or around in the center, just to involve both sides simultaneously. So if you're talking about the extrinsic compression, then intrinsic obstruction, well known about the urolithiasis, and the decreased function is related to the nerve supply or the neurogenic bladders, which can have obstruction with the patients with neurogenic bladders or vesicular-ureteric refluxes and so on. So just to mention this, in this area of obstruction, people are just always impressed that there is a hydroureter hydronephrosis, and they think that this is the way how to diagnose obstructive uropathy. Just for your information, if it's not all obstructive uropathies lead to hydroureter hydronephrosis. So if there is a high suspicion, do not let the normal radiologic findings just dissuade you or sway you from the diagnosis of obstructive uropathy. You might need in this connection confirmation from the by ureterocystoscopy and other measures from the urologist side. And this kind of patients, it's obvious that they need decompression and to care for the post-obstructive diuresis with the electrolyte and fluid and acid-base disturbances. Just also to mention that obstructive uropathy in a good number of patients is associated with type 1 and type 4 renal tubular acidosis. To go to the intrarenal, I think this is a pure area for nephrologists, but just to mention that the glomeruli are involved in certain diseases, the tubules in certain diseases, the vasculature in certain diseases, and the interstitium as well. And notoriously that you find that the acute tubular necrosis and GNs are on the top of the list. In this connection, I know that people might always think about renal biopsies for the intrinsic renal diseases, and this goes without saying. But for practicality, you find that most of the patients who are critically ill, there is perceived risk of bleeding and complication. That's why this dissuades a lot of practitioners just to go for the renal biopsies. But when the suspicion is really high, the only way how to substantiate and corroborate this kind of injuries, it should be through the renal biopsy. Some people might think also about the so-called transjugular renal biopsies. I think this holds true the same with the hepatologists when they do the same kind of biopsies through the intravascular pathway. For the acute tubular necrosis, again, the most common, as we mentioned, etiology of intrinsic AKI, and some people used to use it interchangeably in the past with the acute kidney injury. And the two main components of this one are the nephrotoxic and the ischemic. And the nephrotoxic is really the most prominent agents, like radiocontrast agents, which we are going to spend some time on those. There's a study called the PRESERVE trial, which was done in 2018 with the title of Contrast-Induced Acute Kidney Injury. It proved without any doubt that there is no added benefit of bicarbonate or acetylcysteine use over isotonic saline in patients undergoing angiography with decreased estimated GFR plus or minus diabetes. And this was preceded also by a lot of trials before, just to show that there were different ways just to to prevent or to treat acute kidney injury, and they all proved to be really futile, and there was no really practical use of those kind of things. So just to make it clear that the normal saline is the only thing, hydration is the only thing which can really help to protect the kidneys from the injuries, acute kidney injury. In the same, there was another study called Matrix study, which was also published and showing that there is a radial versus femoral axis in patients with acute coronary syndromes undergoing invasive management. And the conclusion came that in patients with ACS undergoing invasive management, radial compared to the femoral axis reduces net adverse clinical events. The issue after that we're talking, there's something like a subclinical cholesterol atheroembolic phenomena which are taking place. That's why when they go through the femoral pathway, they're going to pass by the aorta, and the aorta is really full of laden plaques and the thrombi and so on. And this, they might take in their way, these ones, and they cause this subclinical cholesterol embolization. This is their way of how they interpreted this one. And lately, in 2022, in April, there was a very comprehensive review of the contrast associated. You see that the term now is different. You're using a less incriminative way of calling the contrast. I mean, in the past, you used to call it contrast-induced acute kidney injury. But nowadays, there's a lot of doubt to cast on the contrast. Is it actually related to the acute kidney injuries? And this is how they concluded. The contrast-associated AKI remains a matter of concern for patients undergoing diagnostic therapeutic procedures that require iodinated contrast administration. And still, we are waiting for the future studies that could clarify the likelihood, clinical relevance of toxic effects of contrast media and the need to develop new prophylactic and therapeutic strategies to improve survival of patients inflicted with the acute kidney injury. So this slide shows clearly this is the verdict about the contrast-associated acute kidney injury. Not all AKI that occurs after exposure to contrast is due to contrast. The contrast-associated AKI is not the cause of the devastating or the disrupting outcomes, but an indicator of patients at high risk of those outcomes in the preserve. So you see the patients having diabetes, hypertension, advanced coronary artery disease, etc., and they're undergoing the contrast procedure. And you do not go back to their comorbidities, but you start to charge or just to try accuse the contrast media. Again, just to mention the randomized control trials, for the arterial side is different from the venous side. So I'm talking about this point for the venous side. The IV contrast and the AKI has never been completed, the RCTs, and probably never will be. This is in contradistinction to the arterial contrast, where, as I mentioned, there is a subclinical cholesterol emboli syndrome, which could be under-recognized. And this is really raised by the Matrix study. As I mentioned, that the radial approach is better than the femoral approach whenever you're doing the angio studies or the therapeutically or diagnostically. So the therapeutic, so the term also wanted to bring this to your attention, the term renalism. The renalism is it's a form of, it's like aversion to carry out the contrast studies, involve the studies or implicated studies, for the fear that the kidneys might be impaired or might be got harmed. Actually, this shouldn't be the policy. I think the doctors who are really suspecting, for example, the cardiologists, most of the time, most of the referrals are coming from the cardiologists. The cardiologists are really positive and clear that the patient is going to benefit from this study. They should carry it out regardless. I mean, because the pros are really outweighing the cons. But you should not stop the patient from carrying out a procedure which could be life saving, just assuming that there might be problems with are going to be there for the kidneys. So again, this is the classical teaching pre-renal as a team universe of the ATN. This is the classical table, just to mention. But there are a lot of, by the way, controversies about this table. It's not really, shouldn't be taken like black and white, because there are a lot of false things which could happen, or a combination of things. But this is for the sake of the classical teaching. Of course, the urine findings. The urine is very important, by the way, in assessing the patients with acute kidney injury. It has different forms of the red blood cells, the casts, white blood cells, crystals, etc. And this can be quite informative of the underlying diagnosis ongoing. Also, there could be common patterns like we have low complements. It could be SLE, could be cryo, infection-related, IG4, nephropathies, endocarditis, arterial embolism. This shows that certain findings can call for a differential diagnosis which should be really worked. As I mentioned, that the urinalysis is really very essential, and it has a lot of impact on the diagnosis. And this should be supported more by quantification of the proteinuria and following of the proteinuria. And these are the urine sediments as well. These are more related to the intrinsic kidney diseases. If we go generally to the CBC, eosinophilia can reflect acute interstitial nephritis or atheroembolic disease, or eosinophilic granulomatosis with polyangiitis. They used to call the Chug stress syndrome before. The calcium is very important, just to request. Serum albumin and radiologic studies. So the urine, blood, and röntgenographies are really very essential. Apart from those ones which are really routinely done, there are extra workup which could include the paraproteins workup for the free light chains and serum protein electrophoresis, immunofixation electrophoresis, and urine protein electrophoresis. All these ones are really important just to clench the diagnosis of multiple myelomas or MUGs and others, and amyloidosis. Serum uric acid is very important also, just to mention, especially for the oncology people. And the suspecting glomerular disease, we should make the preliminary workup, which includes the ANA, the anti-double-stranded DNA, hepatitis screening, C3, C4. We should not go more than that. So ANA, double-stranded DNA, hepatitis screening, C3, C4. These are the basic ones. If you wanted to go further or suspecting something else, you can go to even the recently made phospholipase A2 receptors for diagnosing membranous nephropathy, for instance. The novel biomarkers, this is the second thing apart. After the contrast media, just to get for you, these are not yet clinically available. But remember, the novel biomarkers, they are important ones, because if you look at this cartoon, you got the normal epithelium, and this, if there is ischemia or reperfusion or toxicities, there's a transitional state here in the middle, which is related to the initial damage, and this cannot be picked up with the serum creatinine and urea nitrogen. So the serum creatinine, blood urea nitrogen started to go as delayed biomarkers for kidney injury. So when you find the creatinine up and blood urea nitrogen, don't think that you clinch the diagnosis early, as we might think. But actually, these are the promising future, what we call renal troponins. The same as in cardiology, we have these ones to diagnose the acute coronary syndrome. So unfortunately, we do not. These ones are really important ones. So the definition of AKI, largely, in practice, depends upon the rise in the serum creatinine, which is a marker of kidney function. But the problem that there is a need for a direct marker of kidney injury, as I mentioned, the renal troponins. And these renal troponins can be in the urine or serum, And they are thinking the same way as we are thinking in the cardiology, that there's a CKMB followed by LDH. There is the trajectory of events like myoglobin, CK, LDH, and the troponins. All they come in a panel-like. So they are thinking just to make a combination of those ones. So the availability of these new biomarkers is going to give the so-called diagnosis subclinical AKI. So what's a biomarker? A biomarker, it can identify the primary location of the injury. For example, this will be in the glomerulus, is it in the tubules, and there are different biomarkers are there in the pipeline. And there are all of those ones which are, especially the last two, insulin-like growth factor binding protein 7 and tissue inhibitor metalloproteinase 2. They are nowadays, they are in practice, by the way, nephrocheck. These are urinary markers, and the beauty about them is that they are markers of the cell cycle arrest. So they can pick up the problems of the acute kidney injury as early as possible. The e-alerts, as I mentioned before, that this should be integrated in our computer system, just to alert the practitioners that there is an increase or there is a likelihood of AKI, as we mentioned earlier on. Combining those biomarkers with the resistive renal index, which is the duplex or the Doppler-like studies of the renal vasculature, could also help. So making a combination between the novel biomarkers and the resistive renal index could help, like we're doing the ECG, echo, and the other cardiac biomarkers. For the genetics, there is no genetic pattern is there. For the diagnosis, as I mentioned, it goes with the history taking always should be really well addressed, because these can really pick up the diagnosis very easily. Are talking about a pre-renal, talking a renal, or there's no drug-induced nephrotoxicities on board, or there's the use of any other materials or herbal medications which could have ensued into such AKI. Also the post-renal with the histories of the stones and etc. The uremic symptoms should be also very well known, primarily involving the sensorium, the level of consciousness, and the gastric intestinal upset. And the physical examination could be related to the uremic signs, pre-renal signs. The initial workup, as we mentioned earlier on, related to the urine and the bloods. And these are the novel biomarkers, as we mentioned. And considered, of course, the CK, creatine kinase, always whenever having acute kidney injury patient for ruling out rhabdomyolysis. It's not necessarily for rhabdomyolysis to be associated with a clear history of traumas or crushing injuries. It can happen spontaneously, even due to any medication you might think. If you see that drug-induced rhabdomyolysis, you'll be surprised that any drug really can cause this kind of rhabdomyolysis. And this can be a cause of acute kidney injury whenever you're really stuck with the acute rise of creatinine and you don't know really what's going on with those patients. Of course, for the nephrolithiasis, the non-contrast CT, the ultimate arbitrator, just to tell whether these stones are there or not, and the radionuclide renal scanning just to pinpoint about the isolated split function of the kidneys, and all the otherwise the radiologic studies. Of course, the gadolinium, somebody might ask me, which is really safer? You think gadolinium or contrast? The iodinated based contrast. What do you think? Yes.
The risk of kidney-induced nephrotoxicity is almost 20%.
Yeah.
While in gadolinium-based contrast, it doesn't nephrotoxicity, but it has this disease.
Exactly. So,
occurred 5%, and since 2017, no single case reported in the whole world. So gadolinium is the
exactly, I agree with you. So this is really contrary to our classical teaching that the iodine-based contrasts are really fraught with a lot of complications, unlike the gadolinium, which is safer. It's not true. The gadolinium is really an important issue for the risk of the so-called nephrogenic systemic fibrosis, or the nephrogenic fibrosing dermopathy, which is really fatal. You're going to get all the tissues in the body turned into fibrous tissue. Imagine this one. For the diagnostic procedures, again, as we mentioned, the cystoscopy and the urology workup, and the interpretation mentioned about the kidney biopsies. And for the treatment always starts with the prevention. Nothing starts from the treatment. So the strategies to decrease the AKI, we have strategies with proven efficacy and strategies with possible effective efficiencies. Of course, the avoidance of the nephrotoxins will go without saying, the hydration. These are the primary two issues, and the strategies involving also the daily dosing of the aminoglycosides and the amphotericin Bs and all this stuff. And for the isotonic saline, there's certain protocols for that. But remember the N-acetylcysteine and the dopamines and phenol-dopam and all the ACE inhibitors, ERBs, all what's mentioned about the AKI prevention or so, they are not true, just to be clear. But it's good, by the way, whenever you're having the contrast studies, just I missed this one, to mention that the potentially nephrotoxic medications should be on hold, say, for 2 to 3 days prior and post, like the metformins, like bigonides, ACE inhibitors, ERBs. These are potential nephrotoxic. They should not be given simultaneously or concurrently with the contrast media stories. So what's the treatment of AKI? As mentioned, there's no actual treatment for that. It's all supportive. This is just in short, we have to address all the different, classes, pre-renal, renal, or post-renal. And sadly enough, there will be renal replacement therapy by the end of the day if the patients are proved to be not responding to the medical management. And these are the kind of intrinsic diseases like glomerular, tubular, interstitial vascular, and what are the modalities of treatment on those kind of patients. When we come to the question, also this is a question for the ICU setting people, which one to use? Hemodialysis, is it CRRT? Which kind of CRT? Is it the CVV hemodiafiltration, CVV hemodialysis, etc.? So according to the studies, there is no really advantage of any kind of dialysis over the other. This is one thing. Even the dosage. This is all, by the way, randomized controlled trials. They showed clearly that the intermittent hemodialysis could be used, longer continuous therapies could be there, intermittent versus continuous. There is no evidence in the general continuous therapies are superior to the intermittent ones, etc. Because these are wrongly held beliefs to doctors to use certain modality of dialysis over the other in ICU setting. It depends on the local experience and how efficient or how available these kind of facilities. From place to place, they do differ. So the overall conclusion on the renal replacement therapy in AKI, the CRRT does not confer a survival advantage compared to the intermittent hemodialysis. There's a limited data regarding the ideal timing of the RRT. This is also another story. Are we late? Are we early in starting the renal replacement therapy in ICU setting? Actually, there are lots of studies in this connection, early versus late renal replacement therapy, and there was no really actual advantage of starting early or late. They were almost the same in terms of mortalities in 29 days and 3 months, 6 months, according to the studies. Just to mention also, there's no evidence to support a more intensive strategy of RRT. Some people might think that, well, I have to give more intensive dose of dialysis, dialytic therapy, or the adequacy of dialysis, the so-called KT over V. The nephrologists know this term, KT over V, which can tell you about how adequate the dialysis is. So the renal replacement therapy, we mentioned about that. For the general measures, as I mentioned, that all supportive ones. Also, there's something interesting about the furosemide, that there's a test called furosemide stress test. I don't know if you're familiar with this story. Whenever you got a patient, you don't know this is a pre-renal or intrinsic renal, this is a very practical test, especially for you. For the furosemide naive patients, you have to do this 1 milligram per kg. I think we applied this one. 1 milligram per kg IV bolus, and for the non-furosemide naive patients, 1.5 to milligram per kg. And we see the urine output in 2 hours. If it's more than 200, mean that the furosemide test is really passed, and the patient's read is in pre-renal oliguria, and you have to go on with the usual measures for the pre-renal oliguria, and you can just have expected that there will be recovery for that one, and this will be clear when you give the fluids. Unlike the intrinsic renal failure, you get urine output less than 200 in 2 hours, and failed furosemide stress test. Sometimes they call the first kidney the smart kidney, and they call the second kidney the dumb kidney. This is the way how they describe it in the literature. So hyperkalemia, it goes without saying, the usual anti-hyperkalemia measures. Whenever you're having hyponatremia, this is also an interesting point. People, whenever having hyponatremia, they give them, more salts and so on. It's not true. Whenever a patient is fluid overloaded, oliguric, all what you have to do to decrease the free water intake. It's like a dilution hemoconcentration issue. It's not a matter that there's hyponatremia, there's a low salt in the body. No, there's a high fluids there, making the salts, the sodium seems to be low because of the hemodilution. Okay? For the metabolic acidosis, again, the sodium bicarb to be given IV versus the PO, the pH, if it's really below 7.2, you're entitled just to give the IV sodium bicarb. If the pH more than 7.3, 7.4, better to give the PO sodium bicarb. And this is how we are purchasing it from outside, unfortunately, here. For the second line, as I mentioned, the BOO, the bladder outlet obstruction, all the medications from the urology side. Also, remember that the early referral for the nephrology consultations is very important, just to adjust the issues before they get much more compounded and complexed. If there's a surgery issues, like we have one patient for percutaneous nephrostomy, done already, patient Marwa. Complementary alternative medicines. Remember that there are a lot of herbal and dietary supplements which are actually nephrotoxic. And the patients, you should really investigate these herbal medications, because the patients, they think that this kind of herbal therapies, they are really very important for them, things like that. Misconceptions. And the inpatient considerations, always these patients with AKI, they require admission, goes without saying. And if hypovolemic, require the isotonic saline, as we mentioned. They need a strict intake outputs, daily weights, and all practical points. For the follow-up, of course, nephrology follow-up, and the diet, the main lines of treatment is always, we are talking about the diet, medications, and follow-up, plus or minus renal replacement therapy. So the diet should have its place entrenched in the management plan. For the prognosis of the AKI and the outcomes, sadly speaking, that unfortunately 40 to 20% of patients might die. And even the pre-renal azotemia, this is the one I want to also stress, even the pre-renal azotemia is associated with increased mortality, the pre-renal, with mortality rates as high as 30% in some years. The recovery in survivors is often incomplete. As I mentioned, that there is maladaptive repair. It's like a remodeling. You do not have the same kidneys before, even when you have pre-renal. So there's a scarring ongoing. And there's markedly increased risk of progressive CKD, as we mentioned, and perhaps they might require dialysis at the end of the day. Depending on the cause again, and stages mortalities range up to 80%, as we mentioned. Okay. For the summary and the pills, just to take home messages like quick diagnosis of AKI should be there. To look at the urine always at the preliminary part, not to jump to the sophisticated measures. Look at the urine first. Attempt the initial studies prior to interventions. Do not delay care still. Differentiate pre, post, and intra. Obstruction requires urology. This is from the very beginning, very outset. You have to rule out obstruction. Anticipate, of course, the electrolyte volume, acid-base balance, storage, and recognize for needs of dialysis. Dehydration is not synonymous with hypovolemia. Whenever you talk about hypovolemia is in the intravascular volume contraction, but not necessarily the patient is dehydrated. The oral sodium phosphate solutions, this is also a big issue. Most of the patients admitted high fleet enema. High fleet enema is high in phosphorus. It causes the so-called acute phosphate nephropathy. This is a cause of acute kidney injury. So do not give, please, any patients high fleet enema who's really prone to acute kidney injury, because this will compound, this will really make it worse. Gadolinium, as we mentioned, nephrogenic systemic fibrosis, and the differential diagnosis for the BUN is more than the creatinine, or the creatinine more than the BUN. So again, AKI is a clinical syndrome defined, as we mentioned, by rise in serum creatinine. This incorporates functional damage biomarkers. Early diagnosis is very essential. Acute kidney injury, as we mentioned, describes a sudden decrease in kidney function. Differential diagnosis when known, prerenal, parenchymal, and HN are the most common etiology of intrinsic kidney disease. Most important risk factor for development of AKI, remember, if there's a patient having pre-existing chronic kidney disease, that we have something called acute kidney injury, chronic kidney injury of CKD, and acute on top of CKD. So the acute on top of CKD is really much more easy to take place in those patients who are already having pre-existing CKD. Other than good medical care with the avoidance of volume contraction, prevention of the hemodynamic instability. This is very important, just to maintain the hemodynamics from the very beginning. This has a crucial impact on the kidney prognosis and the mortalities by the end of the day. AKI is highly prevalent, as I mentioned, in the ICU setting. Several strategies to prevent or mitigate the consequence of acute kidney injury. And the future research is almost going to identify certain phenotypes, because the patients with acute kidney injuries are having really a multifarious comorbidities. That's why it's not easy, by the way, just to come up with concrete recommendations, because the different scenarios, you cannot tell which is patients coming primarily surgical problems, patients coming with primarily medical problems, oncology problems, obstetrics, whatever problems. So you have different populations, and this makes it difficult, by the way, just to unify or make a one size fits all solutions. Thank you. Any question? عليك الصلاة والبركاته. الله يرضى عليك. الله يرضى عليك. الله يرضى عليك.
Most of the ICU patients actually they admitted, as you said, that